For our patient, I think there are a few reasonable treatment options that one could consider. For older mantle cell patients, my most common induction strategy is a combination of bendamustine and rituximab. One could consider rituximab CHOP chemotherapy. One could consider a newer regimen called the RBAC regimen, which uses a slightly reduced dose of bendamustine combined with a relatively low dose of cytarabine. And I think one could also consider a combination of lenalidomide and rituximab. So let me walk through those four choices real quick. Bendamustine rituximab is starting to accumulate more and more data as a frontline treatment option in mantle cell lymphoma. It's been compared head-to-head against R-CHOP in a couple of different trials, small numbers of patients, but it was compared against R-CHOP in the STILL trial and in the BRIGHT trial. And in both of those instances, BR beats R-CHOP pretty easily for progression-free survival without any significant increase in toxicity. If anything, it seems to be a little less toxic than R-CHOP. So I like BR better than R-CHOP for a patient like this for an induction strategy. The RBAC regimen, which incorporates cytarabine in with bendamustine, has been presented at some meetings and published, not with very long follow-up at this point. It does produce nice, high complete response rates. The regimen appears to have more cytopenias. There's more neutropenia, more thrombocytopenia. And I've used it a few times, and that's certainly what I see in my practice, is a lot more cytopenias. So is RBAC better than BR? And if so, by how much? And if so, is it worth the added toxicity? I think all that remains to be seen yet. The couple times I've used the RBAC regimen have been for older patients who had really bad biology. I mean, they had Ki-67 rates that were very high, like 70, 80%, very proliferative mantle cell lymphoma. And I was a little worried BR just wasn't going to be quite enough. So that's the occasional instance where I've gone to RBAC, but most of the time I go to BR in patients like this. The lenalidomide rituximab regimen, or so-called R-squared regimen, that's been published in a limited institution phase 2 trial, a couple of centers. It looks efficacious. The response rates were nice and high in the 80-ish% range, CR rates in the 40-45% range. Tolerability looked good. Whether it's better or comparable than BR, you just can't tell yet. And I think it'll take head-to-head trials to really sort that out. So I have not gone to the R-squared regimen as a frontline go-to regimen, but I've certainly used that in the relapse setting at times. So getting back to our patient, I would choose simple, straightforward bendamustine rituximab for his induction strategy. Maintenance therapy has been shown to be beneficial in certain instances in mantle cell lymphoma. For example, in a really large study done in the European Mantle Cell Consortium, patients who received an R-CHOP induction were then randomized to maintenance rituximab or interferon maintenance therapy. And interestingly, the maintenance rituximab was given indefinitely to that group of patients. There was no stop date. That study showed a pretty substantial progression-free survival advantage for maintenance rituximab in that setting, and actually a small overall survival benefit in that setting. There's also a study that was presented at ASH last year, which looked at maintenance rituximab after autotransplant in younger mantle cell patients. And that trial actually showed a progression-free survival benefit and an overall survival benefit. So two pretty strong data sets showing an overall survival benefit, small but measurable, and a big progression-free survival benefit for maintenance rituximab in two different settings. For our patient, the question is maintenance rituximab after BR. And this is a little controversial There was a study presented at ASCO in 2016 from the STILL, which is a German cooperative group. It was kind of a small study, but they treated mantle cell patients with BR and then randomized them to maintenance rituximab or observation. And that trial shows no benefit for maintenance rituximab after BR therapy. And so a lot of folks have taken that as definitive evidence that maintenance is not beneficial after BR therapy. I wasn't totally convinced by the data. It was a pretty small study with just like 60 patients in each arm. And the curve in the maintenance arm was a little odd with a lot of drop off, like right at the 6-month mark. So personally, I have still been giving maintenance rituximab after BR, but I will admit that the data there is not conclusive that it's beneficial, and some data would suggest it's not. And I know a lot of people who do not give maintenance rituximab after BR therapy. So I would say that's an area of controversy.